So we are now going to continue with reading about the exposure. So here, this particular section is dealing with exposure information. We know it's about dietary assessment, and remember our main exposure is fried food consumption both away from home and at home. So as I'm reading, the first thing I notice is on the FFQ. Now FFQ, as a nutrition epidemiologist, I know what type of tool that is. That stands for a food frequency questionnaire. As an expert in nutrition epidemiology, I know that the food frequency questionnaire assesses usual intake, usually over the last 6 months, but it can vary from 6 months to the last year. What is your usual intake? And they usually ask participants to answer a number of questions to assess what your usual intake is. And you can see what those questions are here. How often do you eat fried food away from home, such as French fries, fried chicken, and fried fish? Subsequently, they ask, how often do you eat this food that is fried at home? And so for both questions, you know that the possible responses were less than once a week, 1 to 3 times a week, 4 to 6 times a week, and greater than 7 times per week. Now again, as a nutrition epidemiologist, as an expert in this area, I know one of the pitfalls to a food frequency questionnaire is that participants don't have to respond to the portion size in which they eat. So it's possible that I could eat a French fry every day, but only eat 1 French fry. And so that information is not being picked up by the food frequency questionnaire. So there's nothing, it's assessing usual intake and the frequency in which you consume fried food at home versus away, but you don't know the portion size in which someone is consuming that food. The authors then go on to say how often the dietary data was collected. And so you can see it was in 1984, 1986, and every 4 years thereafter, 1986. The authors then begin to tell you information about how they categorized the data. And so you can see here that fried food consumption was at home and away from home were analyzed separately and also together. And remember, if you go back to the introduction section, we talked about the authors presented biologic plausibility, a reason for why consumption of fried food at home may be different than that of consuming fried food away from home, because there is potentially different reasons. And so what I'm noticing in this next sentence by the authors, a diet score was calculated for each participant. This information still comes from the food frequency, but what I know is that they are trying to assess overall diet score. And the reason that this may be important to note here is some individuals think that people who eat fried food at home may consume a diet that's completely different from those who eat a diet that don't eat fried food. And so what the authors are trying to establish or collect here is information on a potential confounder. Does diet quality confound or distort the true relationship between fried food consumption and risk of either type 2 diabetes or coronary artery disease? Okay, now we can move on to the outcomes assessment. We'll start here at the bottom. Remember, if you recall, the outcomes that the authors are interested in are type 2 diabetes and coronary artery disease. So I know that this information on type 2 diabetes was asked on a questionnaire. Biennial means every 2 years. And they assessed it through physician-diagnosed type 2 diabetes, or MI, in the previous 2 years. And this is self-reported by the participant. That may be important because that may lead to some potential misclassification. However, if you continue to go on, for newly diagnosed type 2 diabetes, a supplementary questionnaire was sent out to gather additional information, and that was the purpose of that was to validate their self-report of the type 2 diagnosis. Some other interesting information, is that type 2 diabetes was confirmed on the basis of criteria from the National Diabetes Data Group Diagnostic Criteria before 1997 and the American Diabetes Association criteria after 1997. Now, before 1997, diabetes used to be classified as insulin-dependent diabetes mellitus or non-insulin diabetes mellitus, or non-insulin-dependent diabetes mellitus, versus after 1997, diabetes was classified as type 1 and type 2 diabetes. Now, the reason I'm pointing that out, or this is particularly interesting, is the difference in classification of how we diagnose an outcome may lead to some potential misclassification of the outcome when we're talking about diabetes. Okay, so now we're going to continue on. The authors indicate that only confirmed cases were included in the analysis, so even though some of this information was self-reported, that gives some strength to say, even though it was self-reported data, this is pretty good, reliable data. So for coronary artery disease, they used medical records and autopsy reports were examined by study physicians. It was these events were defined according to the WHO, World Health Organization, which is a leading organization. And their criteria to have non-fatal MI or myocardial infarction was clinical symptoms and diagnostic changes on an EKG or elevated cardiac enzymes. Deaths were verified using state records. So that's all the information about the exposure and the outcome. We can now move on to the statistical methods section. So right away, as an epidemiologist, I noticed the first thing as I'm reading the first sentence is we calculated an individual's person years. Now you will learn about person years as this semester goes along, but person years for right now is a way we can allow individuals to contribute different amounts of time to a particular study. Now this may be a little bit different than study designs that you're previously familiar with in either research methods or in that public health. In those types of studies, typically we talk about those types of study designs in which everybody starts the study at the exact same time, and there's a pre-test, and then people exit out at end the study at the exact same time, and usually at that time there's a post-test. Now there's a little bit of variability depending on this type of study design that you're talking about, but generally in 201 and 301 you learn that everybody starts and stops at the same amount of time. Now with a cohort study, you're following individuals for a long period of time. And generally when you follow people for a long period of time, some people are going to drop out, we're going to lose track of them, we don't know what happens to them. And what person years does is a way that allows people to contribute information when we know what's going on with them. As soon as we don't know what's going on with them, that information is no longer included. This allows people to contribute data during the time that we know about them. Oops, sorry. And so those person years, just so you know, are based on the date of the baseline questionnaire to the date of the diagnosis, the last return questionnaire, or the end of the study or death. So here the authors are telling us about which multivariate models that they're using. I, as an expert, a nutrition epidemiologist expert, know what Cox proportional hazard models is and means. For this part, we're not expecting you to understand what that particular method means, but what we want you to understand is that a fancy multivariate model was used to examine the association between your exposure and your outcome, and the purpose of this particular type of multivariate model allows you to control for those third variables, those confounders, which may distort the relationship between the exposure and the outcome. And then they tell us that they did these analyses for both cohorts individually. So I know that they conducted the analyses for the participants in the nurses' health study, and then separately for participants in the health professionals follow-up study. And then they go on to say, then they pooled them together. So they did each separately, and then they pooled those two cohorts together. So here, the authors are telling us in multivariate models, which is what the Cox proportional hazard model is, the authors adjusted for the following things: age, white, family history, smoking status, and you can see how the authors categorized that particular variable, alcohol intake, physical activity, total energy intake, and diet quality. And what the authors are telling us here, these are potential confounders. These are what they think the confounders are. Okay. So what a sensitivity analysis means is that the researchers conducted additional analyses beyond these multivariate models. And really all you need to know at this point is that these sensitivity analyses are additional models above and beyond what the authors set out to do. And usually it's a good indication that the authors or researchers were exceptionally thorough at trying to understand what is the relationship between the exposure and the outcome. And so we know that they did a very thorough job not only analyzing that relationship, but thinking about what is the possible mechanism. In women, so the authors go on to say, we also adjusted for postmenopausal status, menopausal hormone use, and this is additional confounders. But these confounders are really only applicable to women because men don't go through menopause. So what this last sentence is telling us is the authors wanted to know whether the relationship, we'll just focus on type 2 diabetes, but remember there are two outcomes, whether the authors wanted to know, okay, if there's a relationship between fried food consumption and type 2 diabetes, is that relationship, does that pathway essentially happen because we know that fried food consumption is related to hypertension, hypercholesterolemia, and BMI, and therefore the increase that we would observe in high levels of blood pressure because we're consuming too much fried food would ultimately lead to high blood pressure, and that high blood pressure would ultimately lead to type 2 diabetes. And so based on this, we can do what's called a mediation analysis. Essentially, they're trying to figure out if these are on the causal pathway, these three variables. Again, they're telling you how often the data were collected in these sentences. Okay, so this is that particular sentence that I just underlined. We stopped updating dietary variables, including fried food consumption, when a participant reported a diagnosis of hypertension, hypercholesterolemia, or cancer. So essentially, the purpose of knowing that is that once people get diagnosed with certain diseases, what we often know is that once you get diagnosed with a disease, you're more likely to change your dietary behavior. And so they want to make sure that when they're studying the relationship between fried food consumption and type 2 diabetes, they're really understanding what their real current and past diet was, not the current change due to your new diagnosis. And you can see here, they also conducted another sensitivity analysis. Again, additional analyses above and beyond what was planned to try to be more thorough and to explain all possible relationships. So when I see the word stratified as an epidemiologist, I know that individuals are interested in the concept of effect modification. And this concept will become more clear to you as the semester goes along. Essentially, effect modification is, does the relationship between fried food consumption and the risk of type 2 diabetes differ by, say, your BMI level? So is the relationship apparent for, say, obese individuals versus people who are of normal weight? So effect modification says the relationship may differ by different groups of individuals. And the effect modifiers that they considered, you can see here, are listed below. And then this is just how the authors tested for effect modification. And that's all we have with the statistical analysis.